Okay, thank you for coming back this evening. We're going to go through a couple of patient cases. I'm going to start with an RA case, and then Christine's going to follow with an ILD case. So we're continuing with the Uncovering the Clues, the case-based journey through ILD and rheumatic disease. The case that I'm going to go ahead and start presenting, I thought RA was about joints. So we're going to recognize and manage RA-associated ILD. This is LBJ, 67-year-old male, complaining of increasing fatigue, shortness of breath with mild exertion over 6 months, something that we learned last week. Past medical history, this patient was diagnosed with seropositive RA 4 years ago, high rheumatoid factor and CCP positive, so double positive, meaning this patient most likely has more aggressive rheumatoid arthritis. Patient was started on methotrexate, then adalimumab was added 2 years ago, giving his ongoing disease activity. So what features here are going to be suggestive, higher risk for ILD? I feel that, really, as we learned, just having an aggressive rheumatoid arthritis, we see those patients in our practice, both in rheumatology and pulmonary. So on exam, this patient's got some inspiratory crackles on auscultation, normal oxygen sat, but this desaturates with walking. Chest x-ray has some interstitial markings. We remember, though, always that, yes, we might have that baseline chest x-ray, but we eventually need to follow through, right, with what we learned getting those PFTs with DLCO and that HRCT, which is gold diagnostic standard. And these are things that, again, we talked about that we're able to order in rheumatology. We see those results there, but then also on that HRCT, those basal predominant reticulations, honeycombing with the U pattern. So again, that basal predominant. So remember, back to our ACR chest guidelines, recommendations for our suspected RA-ILD. We want to follow these patients, get them to pulmonary, but also follow these studies. We get them, we've met and made our network with pulmonary. They're going to confirm the diagnosis of RA-ILD with UP phenotype. This patient has been on methotrexate 4 years, adalimumab 2 years, high rheumatoid factor, older age, male sex, and then that anti-CCP positivity, which does put them in that high-risk profile. So what are we going to do? Baseline follow-up assessments. What are we going to establish for this patient? And should we continue methotrexate? And this is always the ongoing consideration. Initially, we always felt like, gosh, we should stop methotrexate. And I know we get a lot of pulmonary input from our colleagues as well in rheumatoid setting with rheumatoid arthritis. Definitely going to be getting those PFTs with DLCO. Certainly, if pulmonary wants us to order those HRCTs, we can do that. But we want to follow these patients and make sure that we're doing our part in rheumatology and getting that autoimmune disease under control. Working with our colleagues in pulm so they can get them controlled and get that recognition of that fibrotic process under control as well.
So would you, as a rheumatology practice, stop that methotrexate?
Yeah. So you know what? To be absolutely honest, very often we'll say, hold that methotrexate. Okay. Patients on adalimumab, we know that that's going to do a good job controlling their arthritis. And really, I still feel the general consensus is in rheumatology that, is methotrexate irritating the lungs? And I feel we need to hear that from pulmonary.
Mm-hmm.
So what's the strategy? This patient's then going to be initiated on antifibrotic, nintedanib. There's going to be continued low dose some prednisone. Obviously, you want to get this inflammation, controlled. And the patients switch then to abatacept for RA control, and then, as Christine just mentioned, and as I did, methotrexate, putting that on hold, stopping it. Abatacept is definitely a clean drug. Certainly great for RA control. Probably going to allow things to calm down a little bit here while being able to control the immune system and that rheumatoid arthritis. Obviously, checking vaccines, making sure that patient is up to date. And then again, monitoring those PFTs every 3 to 6 months and that HRCT at 12. Christine, do you feel like in our RA patients that's something you're going to really follow and monitor for us, right?
Oh yeah, for sure.
Unless you
For
tell
sure.
us to order it. Yeah.
Yeah, it's easy for us to do that unless there's not good access to a provider locally that is willing to
Right.
do that pulmonary wise. But yeah, the pulmonary can take that over.
Yeah.
I have a question.
So,
Is that okay?
Yeah.
I was just curious with the frequency and PFT monitoring as well as repeat HRCTs, does that frequency change with the risk stratification for the patient? So like with this guy, obviously higher risk due to, male sex, older age, his rheumatoid factors, but do you ever extend maybe some of these intervals for lower risk patients?
Oh yeah. So it working with the patient, many factors come into play. So location of where they live to the place where they come to see us. So if they're not local, sometimes we'll push it out, and then hopefully they can see someone locally in the meantime, just to kind of keep up to date with everything. But we can push it out to about 6 months, especially if we didn't start any medications and we just have mild disease and we've just opted to monitor it. We can push it out a little bit further. But if they're on active drug, like say nintedanib, that requires blood safety monitoring as well, then we would definitely really push for 3 to 4 months for them to come back and do breathing tests. We can update their liver function test, make sure that looks okay. And then looking for any signs of worsening, because the earlier you can pick that up, the better it is long-term wise for them to be treated with something more. And then repeat CT scans, we really don't do them unless there's been a decline or a change in symptoms. So a hard and fast 12-month HRCT follow-up is not necessarily necessary. And so we can push that off for like a year or two if necessary. If they are stable or improving, there's no reason to do a CT scan. It's going to look the same unless we're looking for something specific. But really, it's good to get PFTs because they're a down and dirty version of looking at lung function, and it's nice to have them every 3 to 6 months.
And certainly when we see those patients follow up in our clinics, even if their arthritis is stable and they're showing signs or symptoms of changes, it's easy for us to order as well to help, get that to our pulmonary colleagues as well. Evidence supporting the antifibrotics, we know that continued decline in lung function, we want to stop that fibrosis for sure.
Yeah. I think they had honeycombing on that CT scan. So that's a good time. As soon as you see that, think antifibrotics and put them on there.
And, I think the biologics, I think abatacept is great to continue for the RA. So teaching points, obviously high risk RA patients, and they definitely need proactive ILD screening. And, I can speak to this too, because I have a really great pulmonologist in town here, sent me a patient, real high CCP positive, rheumatoid factor positive. And she's sitting in front of me. She's like, I just don't know what I'm doing in arthritis practice. And at that point, she really wasn't hurting. She didn't have any inflammatory arthritis. But people that have that high CCP and are F3 that potentially could be developing it. It could be a RA stage as well. And so those patients you want to put back on your schedule. I just feel that, you can assure that patient, you're not sure what direction the immune system is going to go in. You're not sure potentially, what's going to happen with the lungs, but it's important for you to follow with pulmonary and rheum. And I know we're all both busy, but certainly putting those patients back on the schedule and also educating them as to what to watch out for further signs and symptoms. So I think that might just be a little bit of a deviation because it's not always like everything sent to you on a silver platter. Oh, high CCP positive or F3 inflammatory arthritis. Sometimes, we're fortunate to capture those other patients. Definitely the HRCT, DLCO played critical roles as we see in early identification. And I believe, rheumatology in these patients, we can help our pulmonary colleagues. They see so many patients. I know you're so busy as well, that if we can say, we've got this patient, we know they've got the autoimmune inflammatory disease. They're in that bucket with rheumatoid arthritis. And now we have this identification with our studies, that helps get that patient in quicker and to be treated earlier before, more damage could be done to those lungs. Looking at that UAP pattern, carrying that poor prognosis, knowing that antifibrotics can slow the decline. again, getting those patients in. I think we're really excited now knowing that we're educated and we can actually help our pulmonary colleagues. And then again, the cross-specialty care with shared decision-making essential. In Wilmington, this community here, we've been able to start our little multidisciplinary discussions, being able to share and be able to get these patients in quicker.
All right. So case number 2, it's getting harder to breathe, progressive ILD and systemic sclerosis. All right. So this is DA. She's a 56-year-old Caucasian woman, worsening dyspnea over 6 months with a dry cough. A known diagnosis of diffuse cutaneous systemic sclerosis for about 2 years now. So she's got some skin thickening proximal to the elbows, some Raynaud's and GERD. She has positive SCL70. So what's her risk of developing ILD? So she has the positive SCL70. She does have the systemic symptoms of the systemic sclerosis with the skin thickening and the Raynaud's. She also has some GERD, which also can be a precursor to having some ILD just from acid reflux, traumatizing those lungs a little bit. And then she's now having, worsening shortness of breath and dyspnea. So you always have to think about possibly ILD coming from that. And then what baseline screening would you pursue? So for her, definitely be PFTs if she has not had any. And then if we on exam hear some things that sound a little bit more like crackles and stuff, we would definitely pursue an HRCT at that point, just so we have a good idea of what's happening in there. But next slide. So worsening dyspnea over 6 months, desaturation on exertion. So a lot of our ILD patients do not desaturate just sitting around not doing anything. It's more from the exertional exercise that they desaturate. PFT show an FVC of 71%, so slightly below normal. DLCO is 52%, which is definitely below normal. It's about moderately restricted. And then these are downtrending from baseline. So they were definitely higher before. The HRCT shows early honeycombing with a UIP pattern. And when you see those two things, we always think about pulmonary fibrosis, and we always think about the antifibrotic medications that go with that to help treat that. So the next steps in management. So we would definitely have a conversation about starting an antifibrotic at that point, because we do have honeycombing, and honeycombing is never going to get better, and it's only going to eat up lung tissue the more it's allowed to sit there and procreate itself. And so we need to consider slowing it down. And would you initiate treatment or refer to transplant? And I never think that is an or question. It's always an and question. So we definitely want to initiate treatment and refer them to transplant. So I believe she's in her 50s, and that's a great time to have a conversation about lung transplant. Now, if she does not require supplemental oxygen, she may not be anywhere near her transplant window at this time, but it's a good first step to get her in front of the transplant people so they can help answer questions and give her information about what it looks like moving forward. And it's always good to do that when somebody is relatively stable and not in a exacerbated state or in a really sharp declining state, because A, they can't take in the information well at that point, and B, they might kind of be trending really quickly out of their window of needing a transplant. So it's good to do it early, and it's fine if they can follow them every 3 to 6 months moving forward alongside of our ILD team to when they do reach that window. So next slide. So they initiated mycophenolate. It sounds like she wasn't on anything at that point, medication-wise, for her systemic sclerosis. So we have initiated mycophenolate for that. We have referred to transplant for consideration, and we've reviewed vaccine needs and introduced palliative care. I think it might be a little early to introduce palliative care for this patient because she is not super progressed in this process, but it's never too early to introduce it. What role do non-pharmacologic interventions play here? So one of the good things that we can do is we can refer them to pulmonary rehab. It is very beneficial for our lung patients to help preserve some of the functionality of their lungs. It also gives them a little bit of a social aspect to see other patients that are in that same situation, and they can talk about their lung disease with them. And it also gives them an idea of how much they can push themselves and still be okay. So we have a lot of patients that are very hesitant to do any activity because they desaturate. And when they see a 90 on their oxygen levels, they get a little crazy. So we want to make sure that, yeah, it's fine. We need you to push yourself with activity. Your oxygen is still going to be fine. If we need to add oxygen, we can add it. But this is okay to exercise those lungs in a safe way. And they teach them breathing exercises and all sorts of things. So it's actually a really good tool to use for our patients. Unfortunately, insurance only covers it once a year for about 12 weeks. So if they can learn and retain that information and take it home with them or join the graduate program, that would be really, really good. And then how do you monitor and adjust therapy? So we would continue to do PFTs every 3 to 6 months and trend our DLCO and FVC. If they are stable to improving, then we're golden. If they are declining, then we would repeat a high resolution CT scan to see if we have more inflammation or more fibrosis. We can always increase mycophenolate, add prednisone, or switch to a biologic like a rituximab or something if it's a lot more inflammation and we're declining. Or we can then add on the OFEV or the nintedanib if it's more fibrotic at that point. So we can go by what the images show us to what direction we want to go in that way. And then definitely we need to add oxygen if they have desaturations below 88% on their walk testing as well. So recognizing high-risk ILD and diffuse systemic sclerosis is super important. Not every patient with these rheumatologic diseases progresses to ILD, but if you start having symptoms of increased shortness of breath, decreasing saturations, cough, there's a high probability that it's happening and it needs to be investigated or sent somewhere where they can do the evaluation. It's important to recognize it early because if you start to get scar in those lungs, it just does not go away. And then it can produce more and really eat up that lung tissue. And then it's not functional anymore. It is very important. So inflammation that is in those lungs at the beginning of the inflammatory process, if it's allowed to sit there for a long time, it turns itself into scar tissue. And so we just want that not to happen. So treating for the systemic sclerosis with the mycophenolate, prednisone, rituximab if necessary. If we can get that inflammation out, then we don't have to worry about as much fibrosis in the end of the day. Initiating immune modulator therapy and timing of antifibrotic therapy. So again, HRCT is super important because you could have two separate processes going on at one time. Inflammation, fibrosis treated differently, but need to both be treated. And so our doctors are much in the school of treating the inflammation first because it's treatable. And it needs to go away and get out of those lungs. And then if they're stable on their immune suppression therapy, then we can add the antifibrotic afterwards. And so that's kind of a way we do it. If we add both of them at the same time, it muddies the water a little bit just in case they have a reaction to something. And so it makes it more difficult to see if they're not tolerating the mycophenolate or not tolerating the OFEV. And we need to kind of figure out what's going on there. And then timing for a referral for transplant and use of antifibrotic. So the earlier, the better for referral to transplantation. And a lot of times we're having the conversation early in the process of meeting the patient at the beginning, just kind of testing the waters to see if they're open to it. A lot of times the moving to Durham for an extended period of time is prohibitive for these patients. They just don't want to do it. Or they don't have somebody that can move with them. So if you know up front that it's not going to be possible, then you don't need to worry about having that conversation. But that can change over time as well. So I had a patient that came in last week who was definitely progressing with his lung disease, on all the therapy that we could possibly be on oxygen, on everything. In the note, it says, we've talked about lung transplant in the past, but he was not interested. And so I had the conversation again. I said, how about now? Are we interested now? We're progressing. We're getting worse. You're feeling worse. What stopped you before? And then we came to the concept of, well, he didn't want to stress his family out at that point. I'm like, well, what do you feel about it now? He says, well, we've talked about it, and I think now we can do that. So now we have referred him over to transplant. He's going to at least talk to them about it. So you have those conversations often. And the only time that they really you don't have the conversation again is they say, I am adamantly denying doing it. My family doesn't want me to do it. I don't want to do it. No way, no how. And then you're like, done. But if you can maybe have the conversation again later, their minds might change a little bit. So don't hesitate to have that conversation. And then antifibrotics, as soon as you see any kind of honeycombing or fibrotic lung tissue that's in there, that is a red siren going off to start an antifibrotic early and often.